Texas. Welcome. Let me give you just a very brief update that we continue talking with the American Academy of Neurology and Neurology N2, Neuroimmunology and Neuroinflammation, about the placement of our neuroimmunology case conference proceedings as publication in Neurology N2 is still a discussion, but I think we're getting closer and closer. I'm hoping to have a resolution and a first time for the inaugural appearance of the paper. So we're very excited about this, particularly for the fellows who have worked so hard on assembling these really very dynamic, challenging patient vignettes. So I think we'll go ahead and start. And Lakshman, you want to go ahead and introduce yourself and where you're from, and we'll get started. And let me just remind everybody, we have two fairly extensive cases to go through. That shouldn't dissuade you from stopping or asking questions, but I want everybody to know that we want to make sure we have adequate time for the second presenter as well. And I know there are quite a few slides in both these decks, so we'll keep things moving, and I will remove myself from the video and leave our fellow present this case to us. Okay, Lakshman, thank you.
Hello, everyone. I'm Lakshman Arkat. I am the Clinical MS Fellow here at the University of Washington, and I will get started with the presentation. So, one second. So this is a 55-year-old male who, and I'm going chronologically, it started in July 2014. He reported paresthesias in his legs, which he felt was submerged in ice. Around November or December of 2014, he started developing gait difficulties with leg stiffness and bilateral leg weakness, which was greater on the left than right. He had an MRI of his L-spine done, which just showed degenerative changes. Moving on to January 2015, he was then seen by neurosurgery for concern of lumbar radiculopathy, and EMG was done, which was normal. And then in February, his gait then significantly worsened, which was worsening over the past few months, and then he started using a cane, which then prompted an MRI of his cervical spine to be ordered. And this is his cervical spine. It showed like multiple cord lesions from C2 down throughout the thoracic cord as well. And as you see in the contrast enhancement in the T1 contrast, patchy enhancement throughout the cord. He was admitted to the hospital, and the initial neurology consult, he got further history, numbness in both legs up to his torso. He had gait difficulties, which are now progressing to him using crutches. He also had perineal numbness and Lhermitte's. And the outside neurologist found spasticity in bilateral lower extremities with hip flexor weakness and upper motor neuron signs with a sensory level. So further tests were done, and the MRI of his brain, which was this was in February of 2015, around 4 or 5 months after all these started. I'm showing you this side of the brain because this will be relevant later. And the MRI brain was unremarkable at that point, and the thoracic spine showed, as we have seen in the cervical spine, the cord lesions throughout the T-spine. Further workup included serum tests with NMO antibody and ANA and Sjogren's, which were negative. He had infectious workup with syphilis and HIV as well, which were negative. Paraneoplastic panel was negative as well. He's a cerebrospinal fluid. He had a protein of 43, but he had negative OCBs, and his infectious workup was negative as well. The first
could I interrupt you for 1 second? Can you go back to the previous slide for 1 second?
Yeah.
It's a beautiful list and a beautiful presentation. Could you just make one comment for the rookies on the line about the copper assessment that you did? Just if you could say a few words just about that. Almost everybody in the line is going to know about NMO, and we're going to look at other causes of myelitis, but maybe you can talk about it with respect to this guy's history of sort of an insidiously slow progressive myelopathy. Why the copper?
The copper can cause subacute, can cause a myelopathy like the subacute combined degeneration, B12 deficiency. If the copper levels are, and then it can be also seen with the zinc denture creams as well. So
yeah, So that original report demonstrated that with hyperzincemia, that those patients have over time significantly reduced copper, and that can be related. So, and it can be other things. We've seen, I heard stories about young people, young women ingesting 20, 30 zinc tablets a day. I love the way they taste and I don't get colds, but now they become myelopathic. So I'll let you keep going. I just wanted to clarify that.
I usually, Elliot, I usually order the two together.
Yep,
although they have the isolated copper deficiencies without zinc as the cause. But and the other thing that's kind of interesting, since we're all neurologists, I presume on this line, what amazing if somebody had bothered to examine this guy before ordering all the wrong things. When all else failed, history and do a physical.
Isn't that something that was exactly the lumbosacral?
Everybody gets an MRI, lumbosacral, and if you're 55 and you have a normal one, they X-rayed the wrong person because no one does. I mean, it's really
that happens all the time, though, right? I mean, that's almost routine.
But that's why they're not getting rid of us any too quickly, Lakshman. So you're in good shape. Your job is secure.
Right.
I'll let you keep going.
Like a CT with the head in Guillain-Barré, but they're working at the wrong end, the other wrong end.
Yeah. Okay.
So during this hospital course, they also did CT abdomen and pelvis, which was a negative for any malignancy. He was treated with 7 days of IV steroids, and he was discharged on a taper. Looking back, he said he responded well to steroids and is able to cautiously walk without crutches at the time of discharge. And his sensation in his feet also continued to improve, and he no longer had the Lhermitte's phenomenon. Post-discharge, so he was not seen by us initially, he was seen by an outside neurology provider, and the working diagnosis was between multiple sclerosis or seronegative NMO, as the NMO had been negative. He was started initially on fingolimod, and then he was started to taper down on the steroids. And as we were tapering down on the steroids, there was worsening of sensory symptoms when he was going down on the steroids. He continued to have this spastic gait, which he noticed was worse after the steroids, and he completely went off the steroids in August 2015. And
I have to interrupt you for one more second, and that is, correct me if I'm wrong, but at the beginning, what I found most salient was the fact that, first of all, everything begins somewhere. The patient becomes symptomatic. My legs are like in ice water. But if you looked at the story between July and February, correct me if I'm wrong, this was not a series of cataclysmic events or acute exacerbations. It seemed to me that the course was more insidious, progressive, but more insidious. And that would make NMO on any continent and on any planet I know highly unlikely. Maybe at some point we'll see it published, but every NMO patient I've ever seen have these very paroxysmal events, like exacerbations with MS, rather than a course that like
they relapse. They do not progress.
Yeah, and yes, I totally agree that it was a progressive onset, making NMO very unlikely. At least I have not heard of.
During the blood study, Lakshman, I think with that MRI, there's no harm in doing it, but it would be an unusual NMO, as Elliot said, to go much more like an HTLV1 or a primary progressive MS, which the MRI doesn't look like either.
This is Doris, and I'm going to interrupt briefly. Scott Zamville has a comment in the chat. I guess IgG index was normal. Is that correct?
Yes, all markers for the MS panel were normal.
Okay, and then he has followed up and says it does not seem to fit MOG either.
Yes, and we did do that. I'll come to that later. But we did do that. It was still maybe going on that NMO spectrum disease, even though the history did not fit with the progressive symptoms. I'll come to that.
Lakshman, can I ask you a quick question? You mentioned HIV negative. Was HTLV1 done? Although it's a little unusual for it to start as high as cervical. They're usually mid-thoracic, but that does have a slow kind of course. So no HIV, I don't know about it. It's the outside HTLV1.
Yeah. Yeah, I totally, yes, and that is part of the transverse myelitis workup, but looking back in the record, it wasn't done, to be honest.
Even without bands, that would be worth doing, I think.
Yep. It's a great
Yes.
point.
Point.
One of the things people will give you differentials for NMO, primary lateral sclerosis, MS, sarcoid, and one of the things they really commonly forget, I see this here in the program as well, is the HTLV1. So I think Bob's point is very well taken. Okay.
So this was the first neurology consultation at our facility, and we had now a spastic paraparesis in a patient with a progressive onset of worsening of his gait, multiple cervical cord lesions. As you know, his MRI brain did not show anything at that point, and he was fairly responsive to steroids. His exam showed the spastic paraparesis, some mild weakness in his left upper extremity with hyperreflexia and upper motor neuron signs. Well, we expanded our differentials as we see someone for the first time, though it was unlikely this progressive onset with NMO. We did keep multiple sclerosis and NMO with also neurosarcoid as well as lymphoma on our differential. And we planned for more tests. We repeated the brain and the spine, repeated the aquaporin antibody because at that point I think only ELISA was available, and now we had the cell-based assay. And the LP, a repeat LP to basically look for the flow cytometry and lymphoma markers and a PET scan. So this is what our plan was. We wanted to continue the fingolimod until we knew more. And then when we repeated the brain MRI, we had this, as I showed you the sequence in the first MRI, and now we had enhanced hyperintensities in the superior and middle cerebral peduncles, as well as on the midbrain, as well as in you see the optic nerves and on the optic chiasm as well, on right more than left. And looking at the enhancement, we see all those areas pretty much enhanced, as you can see around the cerebral peduncles, around the midbrain, as well as in the optic nerves. So this was new since the first MRI.
I can ask one question. Some of these are in the dorsal medial lateral pontine tegmentum, and this one over here that's the comma looks like it's in the right superior cerebellar peduncle. So at this point it's present. Does the patient have dysarthria? Do they have ocular contrapulsion? Do they have an ocular motor issue, an INO, an outflow tremor, or are they asymptomatic?
So he did not have any obvious brainstem symptoms, but I did not include in the presentation. He did have several episodes of transient paroxysmal dysarthria, which were confusing for seizures initially. Episodes where he just had problems where he couldn't speak for a few seconds, and it used to last for a few seconds, and then he got resolved. And we were a bit stumped by that initially. Whether it was a seizure, he was ruled out with the EEG, and then afterwards it was thought maybe it was related to the brainstem symptoms, and he was put on carbamazepine, which tended to improve those symptoms. But that was
I'm just curious, would people agree, though, I know the subacute course is not at all appealing for NMO, spectrum disorder, but if you look at the radiology and you have these periventricular, fourth ventricular enhancing lesions and sort of longitudinal myelitis, that is very appealing for the diagnosis. So you know,
among others, yes, I agree. Yep. And as
when-
Lakshman pointed out, that again, I want everybody to look. If I don't know if you have an arrow, Lakshman, but the second image from there you go. This is right in that right superior cerebellar peduncle. Let's remember that most of the radiation, the tract systems, the dentatorubro-thalamo, dentatorubro-vestibular, most of these are coming out of the superior cerebellar peduncle. There's also a favored place or location to have a peculiar eye movement problem where people will have overshoot saccades away from that lesion and undershoot toward that lesion. This is contrapulsion, which is the reverse of what you see with Wallenberg syndrome, where they get overshoots to the side of the lesion.
The other thing, because a lot of us have obviously looked along the slides put together so beautifully, the one on the far left, as you're looking at it, is the only one that looks like a little. This one is the only one that looks like a little circle, which will be interesting later.
Yep. Okay, Lakshman, let's keep going.
Yep. And so this was his CNT spine. There was some interval improvement of the T2 hyperintensity throughout the cord levels, but there's still remaining some patchy enhancement at certain levels of the cord. more specifically in C6M. So we did the PET scan, or whatever we planned to do. The PET scan had no evidence of any malignancy or any sarcoidosis. The repeat LPs, because we already had one, we wanted to rule out lymphoma, and we had 2 more negative LPs for flow cytometry as well as cytology. Ophthalmology did not find any evidence of prior optic neuritis on their exam. The aquaporin antibody now was -1 by cell-based assay, and previously also by ELISA, though there was a question because it was done at the same time after steroids, we repeated it again. And the MRI neck was negative for any vascular malformation, so pretty much ruling out anything else which would cause a spinal cord lesion. So we decided to stop the fingolimod and switch to rituximab with the possibility that we're trying to prevent more damage, and possibly this is some kind of seronegative NMO, even though the presentation didn't fit completely. And he was also started on oral prednisone taper till the rituximab start.
Just a quick question. Can I interrupt for a second? I'm curious, was there any washout between fingolimod and Rituxan?
So there was a gap of at least 4 months because of insurance problems. Not that, I don't think it was planned. But usually we wait a couple of months for the lymphocytes to come back before we start the B-cell therapy.
All right, thank you.
Rituximab is starting to be used sort of like IVIG. I don't mean in this case, like IVIG. If you don't know what else to do, it's an immune disease. Why not do something?
I totally agree there.
Well said.
So he was continuing on oral steroids till we could get the rituximab started by insurance, and he did try briefly azathioprine in the interim because we felt that we wanted to protect him in some way. He did not tolerate that, however, unfortunately. We had a repeat MRI brain while on steroids, and he had not yet started the rituximab, and you see that area which I showed you that in the contrast now is resolved. There was a resolution of a lot of enhancement of the areas. But 3 months after the start of rituximab, we were back to having enhancing lesions, some in the same area, some in different areas. Here we see here in the around the midbrain, as well as in the cervical spine, and around the fourth ventricle bilaterally.
And the very favorite middle cerebellar peduncles.
And so this was radiological. He had some clinical worsening of his gait, and he also had radiological worsening on the rituximab. And as we see that in the MRI, his B cells were 0 post-infusion. So we decided to start him back on oral steroids, and we started back on prednisone 50. We also did additional immunosuppressant with mycophenolate mofetil in addition to the rituximab. So we were thinking what else could be something which does not respond to rituximab. So we expanded it to other kind of zebras, Alexander's disease, Erdheim-Chester, Keppel lymphoma on the differential. We had not sent anti-MOG at that point. We also thought maybe a possibility of biopsy, so it was sent to neurosurgery.
Lakshman, one quick question. There was no evidence of palatal tremor in this guy, correct?
Not to my knowledge.
Not only tremor, but that's a very strong concomitant with Alexander's disease. But okay, go ahead.
So he had an X-ray bone survey, and there were no bone lesions suggestive of Erdheim-Chester. The genetic testing for Alexander's was negative as well. At that point, the Mayo Clinic assay hadn't been available, so we sent anti-MOG to Oxford, UK, and it was negative. Neurosurgery felt that the areas were too eloquent areas, so they wouldn't be, the biopsy would be too risky. So going on to how his course was after he was still continuing on rituximab, and he was on oral steroids for the rest of the year through 2016, and he had stopped. And there'll be another slide which shows that he stopped the steroids, tapered off the steroids in January. We saw some kind of worsening of the hyperintensities around the middle cerebral peduncles in February. There may have been some decrease in intensity in May. The enhancement, however, remained stable while he was on steroids, but he would continue to be on rituximab as well as CellCept. And in January, where he tapered completely off the steroids, the enhancement on the middle cerebral peduncles remained stable, but we had 2 new enhancing lesions in May and July, which I will show you in the next slide. So he had another punctate enhancing lesion here in the left midbrain, and then he had another one in the right midbrain. The left midbrain one persisted even in July. So these were off steroids while still on rituximab. So our working diagnosis at this point, because we ruled out everything else, was could this be Clippers? So there were a lot of clinical features which didn't fit with Clippers completely. We didn't have many. We had the dysarthria. We didn't have any diplopia or ataxia, and we had myelopathy and paraparesis, which can be seen in Clippers. The lesion distribution outside the pons, it's not restricted only to the brainstem. It can be seen in the basal ganglia as well as spinal cord, according to the initial 8 cases reported by Sean Priddock. Inflammation beyond the brainstem. So this is something I didn't know all of this before I read up on it. That beyond the brainstem, you can have on autopsy cases as well as on MRI 7 Tesla. They did find widespread perivascular inflammation extending up to the basal ganglia, the parietal cortex, and even up to the cranial nerves. But we always expect that the degree of inflammation is less at the greater distance from the brainstem. So we expect more number of brainstem lesions in the more number of lesions in the brainstem or the cerebellum. So what we did was we started him back on a lower dose of prednisone, and we're currently planning on a very slow steroid taper. We started him on 40, and we're now down to 20. We stopped the mycophenolate because we didn't feel that was doing much, because he was still having enhancing lesions while he was on the second immunosuppressant. We still are going to keep him on the rituximab for now, but we're not pretty sure that it's completely helping. He had a couple of MRIs since the start of the steroids, and he's had stable enhancement in the middle cerebral peduncles and no new enhancing lesions. And the MRI spine has been stable throughout since the initial couple of scans. So
very nice. I was having trouble finding that Blodsberg, but today. But the thing that's interesting is that his clinical first manifestation and his MRI were the spinal cord. The brain was normal. So I guess the idea that it's always most striking, at least maybe in the beginning, in the brainstem and the cerebellar peduncles and so forth, may not be always true. At least this case, if
yes.
This indeed is. And then the other thing people keep forgetting about mycophenolate and azathioprine, if you look at the literature in myasthenia, these things don't work really quickly. So our study in myasthenia, then late John Newsom Davis and Jackie Pallas's study, it takes 6, 8, 12, 14 months to get a full effect. And in fact, the mycophenolate studies in myasthenia, part of the reason they, quote, failed is that everybody was convinced, Lord knows why, that it would not only be effective, but it would be twice as fast as azathioprine. So instead of the Newsom Davis, Jackie Pallas 2-year taper, which was also used in the thymectomy trial, they did a 1-year. And of course, when you try to solve an equation with 2 unknowns, you got a problem. So I always worry about people giving mycophenolate and azathioprine for a few months and saying it didn't work when we know that may not be true.
Let me echo that, Bob. This is Elliot Froman with our work on mycophenolate in patients with multiple sclerosis and in combination with other agents. That's exactly the case. And it's also important, Lakshman, to make sure that when patients are on that drug, that you make sure they're not only taking it, but taking it correctly.
Right.
We've seen lots of people come in with breakthrough disease. They're failing mycophenolate. They're not failing mycophenolate. They're failing to take it correctly. If this was a transplant recipient, you'd know about it because they'd be in transplant rejection. And what I'm talking about with respect to correctly means empty stomach, an hour before or 2 hours after a meal. I cannot tell you how many people's eyes move in the back of their heads when I bring this up because they never told the patient this, and they're not failing. That's a false negative. I mean, it's just the bottom line is you've got to really make sure it's correct.
You can get levels, but you don't need it if the patients take it correctly.
Exactly. Exactly.
So Dr. Froman, this is Ram. I have a quick question.
Okay, before you ask the question, let me tell you who this is. This is Ram Narayan. He's the 2-year fellow at UT Southwestern, started with us. He was at Hopkins and NIH for a while. And he is the other Clippers expert on the line with you, Lakshman. Okay, Ram.
Yeah. So I actually did medical school with Lakshman, Dr. Froman. So, yeah. Would you guys consider sending GFAP antibodies in this patient?
Doesn't fit the original description. I wrote the editorial on that one, although I gather a larger series is in press. And again, when you have a larger series, and again, some of the patients in the larger series, I gather from Sean and others are not all at the Mayo, so you got to worry a little about some of the clinical description. The way they picked that up was on when they do the immunofluorescence on the paraneoplastic, just the way they Vanda and the others picked up the aquaporin 4. Somebody said that's a kind of a funny pattern. So I think that the Mayo people, the techs, are pretty attuned to quickly yelling for either the Mayo fellow or Sean or Vanda or Andy or to come and take a look because I got an oddball pattern. If it's a fixed or frozen tissue, GFAP should show up pretty quickly on a screen. Nothing else looks much like GFAP except Vimentin, and I don't know of any Vimentin antibody syndrome. So it's an intermediate filament, so it should show up. But I don't know that you can order it specifically. I think it's part of a panel.
And as long as we're bringing it up, Bob, because there are people on the line who may be rolling their eyes, this is glial fibrillary acidic protein. This is a marker where we tend to look at, Bob is right, these 10 nanometer intermediate filaments inside astrocytes. And the implication is this a different astrocytopathy in contrast to the NMO-IgG aquaporin, which is a different astrocytopathy, and differentiating that from the anti-MOG, which is an oligodendrogliopathy.
And the thing about the GFAP syndrome, since that's not an exposed antigen, it's been postulated, and there's some dog model of it and so forth, that like the anti-A2 or the ANA type 1, the antibody's a marker, but it makes the CD8 T cell attack on the cell instead. And of course, T cells don't need to have a surface marker to go after, so it's not an antibody.
One last thing for the purpose of time, I'll take Chair's prerogative. Lakshman, I want you to pull out our paper or send me a prompt on email. This guy has recrudescent smoldering coming back and again. And if you're right, if this is a Clippers variant in some way, there's perivascular or lymphocytic inflammation, you have to kill those cells. So I would like you to take a look at our paper on high-dose methotrexate with leucovorin rescue. And we've treated a number of patients with a variety of fulminant inflammatory demyelinating and non-demyelinating syndromes where it has been nothing less than spectacular. We recently did it on a post-Tdap encephalomyelitis. Almost the entire hemisphere was involved. And we treated that patient. Obviously, that was a multi-wavelet ADEM patient. We did it in somebody who had encephalomyelitis post-adenovirus infection. We've done it in NMO, MMS, and also in Clippers. So I would like you to take a look at it and just think about it. And Ram Narayan is I believe, is an author on that paper. I think he is. And I think it's an important option, particularly given the fact that this guy is still recrudescing.
The other thing that are, Elliot, would be cyclophosphamide, which if you
of course
do it the right way does get some penetration, especially if you got a leaky barrier. And the other thing that's being used more and more when even rituximab doesn't work, the other magic is anti-IL-6, but that won't kill, but it would suppress inflammation.
Yep. Okay, so Lakshman, any last comments before we go to the second patient?
I was wondering what you guys are thoughts on Erdheim-Chester. Would that present? Is there any other way to check for it other than doing a skeletal bone survey? I know that for it to affect only the CNS is pretty rare.
Yeah, pretty rare.
Yeah,
in
and
recent papers, but usually you're going after those bone cysts, which are these non-Langerhans giant cell histiocytes, and it doesn't fall into the category of the other histiocytoses we think about. But that's a great question. I think we got to look at that when there's been a few recent Erdheim-Chester papers published. Anybody else on the line? Ed Fox?
Yes.
Any of you Esther?
You can check on serum for BRAF VE600, and the patient that I presented in my case, he had positive BRAF in the sample in the biopsy, but also it was present circulating in serum. So that might be a possibility that without being very aggressive.
Thank you for that. And then if you see it, as long as we're on it, then the question becomes one of, what about the management?
What about ILs, anakinra, and those, the IL receptor antagonists? I don't know whether that would be an option for Erdheim.
Well, I think we'll leave it there. And this is fabulous.
IL-6 is tempting for that any cell that comes out of that cell, the cell's origin.
Okay. So Doris, if we can transition, let's go to the second patient. I know this one is going to be even more lengthy than the first, but I'd like to congratulate you, Lakshman. I look forward to getting the transcript from the MS Society. We'll share it with you, and we'll have discussion with you along with mentors about preparing a write-up. It's a beautiful presentation. I really appreciate it.
Thank you. Thank you, Dr. Froman.
All right, so I just transitioned it over to Laura. There we go.
Hey, Laura, we can't hear you. I think you're on the mute.
Laura, we can't hear you.
Okay.
There we go.
There you go.
All right. Perfect. All right. Hi, everybody. I'm Laura Baldassari. I'm one of the clinical fellows here at the Mellon Center at the Cleveland Clinic. I'm going to talk to you today about a case I actually saw in residency that is near and dear to my heart, and I thought would be interesting for everybody to discuss. Okay. So what we have is a 33-year-old woman who's coming in with bilateral leg weakness, abnormal movements, and altered mental status. Sorry, I'm on a different computer than usual, so there we go. Okay. So she's coming in to an outside hospital with about a 2-week history of bilateral leg weakness. And she had this intermittent similar symptoms for the past 4 years that she had noted. When she was at the outside hospital, she noted that she had left leg twitching. She noted some diplopia. Her thinking was slowed, and she had difficulty expressing herself. Her family members also noted that she had kind of impulsive behavior, questionable judgment over the past few months, kind of doing things that were atypical for her. And unfortunately, by the time she got to us, the history that we were able to get was limited due to her mental status, as well as the unavailability, unfortunately, of her family members at the
Laura,
time.
one quick question. Do we know whether the diplopia was vertical oblique, or whether we understand these were vertical eye movement problems, or were they strictly horizontal, or we don't know?
We don't know, but when she came to us, the exam, I think it's just kind of, I think probably disturbed eye movements is a better way to kind of think about it. But what she reported at the outside hospital was diplopia. Right. Yeah. So at the outside hospital, she had progressive weakness of her lower extremities that came on quite acutely. She became paraparetic. She developed urinary incontinence, dysphagia, and encephalopathy. And then her course was further complicated by a pneumothorax and pneumomediastinum when she had an LMA airway in during the MRI that she had with sedation. She then developed a fever, and her encephalopathy worsened, so she was transferred to our hospital for further management and evaluation.
So what are you keeping?
So her past medical history, she had a report of hypertension, anxiety with possible bipolar disorder, and also she reported polycystic ovary syndrome, surgical history only notable for a C-section. Her home medication list was interesting at the time of admission. She was on Celexa as well as Paxil at the same time. The doses were kind of unclear, as well as kind of a myriad of other things, clonazepam, lamotrigine, and gabapentin. Her social history, again, was kind of limited, but what we've obtained from her mother is that she drank 1 to 2 alcoholic beverages daily, and she smoked 1 pack of cigarettes per day for the past several years, and her drug usage status was unknown. Family history, no history of seizures or other neurological diseases, maybe some autoimmune disease with mixed connective tissue disease, as well as type 1 diabetes. So her general medical exam was quite remarkable, as was her neurological exam. So she was febrile and tachycardic. Her head and neck exam, she had bitemporal wasting, she had nuchal rigidity, and then not surprisingly, given her recent history, she did have decreased breath sounds on the left from her pneumothorax. Her neurological.
Let's reiterate, she's 33, right?
That's right, yep.
Okay, thank you.
No problem. So her mental status at the time of exam, I have a really a great video that kind of conveys this, but I was unable to put it up for here because it's recorded and it's protected, unfortunately. So I'll try my best with the description. So she was alert. She opened her eyes spontaneously, but she wasn't really regarding, tracking, not following commands. And she kind of had this constant train of nonsensical speech.
Did she work in the White House?
What's that? Well, now that you mention it.
Beautiful.
I couldn't resist. Sorry.
Oh no, it's okay. Her cranial nerves.
10 points to Dr. Froman.
Her cranial nerve exam was a little limited at the time because of her mental status, but from what we could tell, she blinked a threat bilaterally. Her pupils were equal. Her extraocular movements were full, but kind of erratic, and her eyes were just kind of darting all over the place, but appeared conjugate. Her motor exam was pretty remarkable.
Laura, I'm sorry, I have to stop you. When you say darting all over the place, in retrospect, you don't think, and look, you're at Cleveland Clinic, you know this. This was not ocular flutter. This was not ophthalmos, right? Okay, sorry, keep going.
Oh no, that's okay. That's okay. She was.
They weren't back-to-back saccades with no intersaccadic latency, which by definition makes these the most extreme kind of intrusions, like flutter or opsoclonus. Okay.
Right, exactly. And yeah, that's not what they looked like. Yeah.
Okay.
So for her motor exam, so she had pretty marked rigidity, more so in her lower extremities than her uppers. She was holding her upper extremities flexed and her lower extremities extended. She was at least anti-gravity, but was of course weak in all 4 extremities. And she also, her exam was notable for diffuse intermittent myoclonus, which is a big part of her presentation at the time when we first saw her. She was also hyperreflexic with 4 to 5 beats of clonus at the bilateral ankles. So our first kind of evaluation that we did, so just kind of basic labs that we started out with when she got admitted. Her CBC was unremarkable. She had some hypernatremia. Her LFTs were normal on admission and became abnormal over the course of her admission up to the 500s and 600s. Her coags were slightly abnormal at the time of admission. Urinalysis was notable for Luke esterase, so potentially consistent with urinary tract infection. Her drug screen was negative, but she had been in an outside hospital for several days. TSH was normal, HIV and RPR were negative, and her B12 level was normal as well.
She's obviously pretty dry too.
Yes, yeah, definitely. Yeah, but she was not in great shape. So her initial expanded labs that we got, she had an elevated ESR and CRP. Her CK was normal on admission and then increased to over 1,000, also with an elevated aldolase. She had negative ANA, ENA, and ANCA initially, as well, and her serum NMDA antibody was negative. Her thyroid antibodies were negative, as was lactate pyruvate, as well as the ratio. Her LDH was elevated, and her iron panel was notable for a low total iron binding capacity, and her hepatitis panel was negative. And I apologize, there's a lot of workup that went along with her, so I'll kind of get into the hospital course in just a minute. So due to our initial concerns when she was admitted, we did a lumbar puncture immediately. She had 0 nucleated cells, normal protein and glucose. She had a mildly elevated IgG index, and she had 10 unique CSF oligoclonal bands. we sent an NMDA kind of initially, and the CSF NMDA antibody was negative. And then in terms of an infectious workup, we sent HSV PCR, VZV PCR, EBV, CMV, enterovirus, crypto, fungal culture, and then an aerobic culture that were all negative.
Laura,
yep.
Just on the lab. So the late Don Gilden used to point out that while we are all enthralled with PCR, you could miss it. It's sort of like in the blood, if it's a viremia or CSF, you know, in and out. Right. So Don always said at the same time, and maybe you guys did this, to also order IgG and IgM antibodies in the CSF and the serum to the ones you're really serious about. Because if you find an M, you may miss the VZV. I'm not saying she has VZV, but you might miss it. But if you find high M in the CSF, it has no business being there unless something is involved. So Don used to always, and he had that nice little book on the neuroinfectious disease that was all case histories. And he had a couple of where he could show that the antibody sometimes will sort of raise your index of suspicion when you can miss the PCR.
No, definitely. That's a great point. Thank you. I don't think we did end up checking a VZV antibodies in her CSF, but we kind of went down another route.
No, I'm just saying it's an interesting point he makes, because everybody thinks PCR is the most sensitive, which it is, but if it's transient, you miss it.
Right, exactly, especially after like an acute infection, but potentially causing neurological sequelae for sure. Okay, so her initial brain MRI was kind of underwhelming at first. There was some and I'll show you on the next slide here. There was this was an admission down here on the bottom, if you can see my arrow, maybe within the normal limits, but maybe some increased signal in the caudate. And we saw there's kind of some scattered, non-specific, very small T2 hyperintensities. There's no evidence of contrast enhancement on her admission scan. But the thing that I wanted to point out with this imaging is the difference between the admission and then the 2 weeks post-admission scans, particularly on the T1. You can see that she does have a degree of atrophy that's progressed relatively abruptly, I think, over that 2 week period. Her sulci look more prominent, which was very concerning to us.
Laura, one other question. I assume that the DWI did not show increased cytotoxic or increased signal in the caudate or the deep gray matter.
That's correct. That's correct.
Because later on you get into a differential where that can be a big clue.
No, definitely. Okay. So we also did kind of on her initial presentation, due to her abnormal movements, we got a routine EEG that showed kind of moderate generalized slowing, no epileptiform activity, but video EEG did show some intermittent bilateral synchronous sharp waves frontotemporally, and then the myoclonus that she had did not have any EEG correlate. So what we did initially, when she came in, as I mentioned, we did an LP pretty quickly because of concern for infection. But our differential initially included autoimmune or infectious encephalitis, serotonin syndrome, given the fact that she was on both paroxetine and citalopram at home, as well as her presentation with fever, rigidity, and hyperreflexia. We're also concerned about neoplastic or paraneoplastic etiologies, potentially a toxic metabolic encephalopathy. However, kind of our first clue with her was the presence of unique CSF oligoclonal bands that was concerning for an autoimmune process. So initially we gave her 5 days of empiric methylpred with really minimal to no improvement in her symptoms and mental status. And concomitantly, we started broad spectrum antibiotic coverage, kind of empiric meningitis coverage at the time because of our similar concern as her cultures and studies were coming back, and we pulled off the antibiotics as the testing came back. We also treated her kind of empirically for serotonin syndrome with ciprofloxacin, Ativan, and we of course held her serotonergic medications. And unfortunately, there was no improvement in either her fever or mental status over this time period. So at this point in our hospitalization, we did get some more kind of expanded labs. At the time, this is like back in, I want to say 2014 or 2015, the labs, the paraneoplastic evaluations that were sent to the Mayo Clinic included the antibodies you see here, and they were all negative. So we have both in serum and CSF, we have MA1, MA2, the potassium channel antibodies, calcium channel antibodies, and then ANO1, 2, and 3. Other expanded labs that we sent during her stay at this point, she had a normal serum amino acid profile due to our concern for kind of metabolic etiology. Beta-2 microglobulin was normal. Her ceruloplasmin was normal, as was her copper, 24-hour urine copper. Her ferritin was elevated, but again, not specific in the setting of her presentation. We checked for heavy metals. We checked for urine porphyrobilinogen, which was normal. And then due to her abnormal movements, we checked a peripheral smear, and that did not show any acanthocytes.
You want to make a brief comment about acanthocytosis, Basen-Kornsweig, and neuroacanthocytoses for the rookies on the line? Just a brief comment.
Sure. So acanthocytosis has been associated with kind of acute to subacute onset movement disorders. Specifically kind of like myoclonus and tremor in patients. So that's we're thinking about that there.
This is Doris, and Ahmed has a comment in the chat feature. He wants to know NMDA from CSF.
Oh yes, we sent that, and actually I think it's on the next slide or a couple slides from now.
That was previous slide. You had a previous slide with that.
Okay, and then Bilal is asking whether the protein 1433 was sent.
Yes, and that's actually coming on a subsequent slide.
Let me also mention that as much as I like oligoclonal bands to be autoimmune, our neuroinfectious disease pals like to point out the reason some of them still hold out that MS is an infectious disease is that most diseases that have unique bands are actually infectious. So just
no, definitely we were concerned about infection as well.
Obviously, we worked her up for that and treated her until you knew otherwise.
Right, exactly.
Yeah.
We kind of had parallel things going on at the same time because she was so sick.
Absolutely.
Laura, this is Ram. Did you mention earlier that MRI spine was done, or did I miss it?
I did not mention it, but it's actually on the next slide, and her CNT spine was normal. I don't have the images. I didn't put the images in, but it was normal.
One last thing, I see that here you have duodenal biopsy for Whipple's, but in the modern era, particularly with the rather promiscuous use of antibiotics in many of these cases of CNS Whipple's, the jejunal biopsies are negative, but we do have both smears to look for Whipple's bacillus, but also PCR for Whipple's and CSF. So were those looked at? With the issue of part of why I asked about vertical eye movements, we have myoclonus, cognitive alteration. So it does raise the specter of a treatable disorder. So that's a question.
Usually, though, Elliot, the ones that were reported out of cases, one out of place by Sunitha Santhakumar and a couple of the residents, they had stuff in the brainstem on the MRI. It doesn't have to be, but they usually do in the appropriate area for those eye movement problems.
That's right. Not to mention that one abnormality that only occurs in Whipple's, which is oculomasticatory myoarrhythmia, which are the pendular convergent eye movements synchronized with jaw dystonic dynamic movements, which this patient didn't have. Right. Which is not always present, maybe 25–30%.
But the lack of seeing something in that upper part of the stem is a little against it.
Right.
There's always a first case, so you never know.
No, definitely. We were very concerned about her because of her lack of improvement on both treatment for autoimmune and infectious causes at the time. So I think at this point we were definitely looking for more zebras, definitely for sure. So as you can see, there's a couple of other infectious studies that came back negative. We sent Lyme antibodies in our CSF and serum that were negative. We sent a blood Ehrlichia PCR, which was negative. We repeated her CSF with several other studies. CMV, EBV, enterovirus, and cryptococcal antigen were negative. We sent an HIV viral load to the possibility for a negative antibody if she was kind of acutely converting or acutely infected. And then we actually thought about SSPE and checked CSF rubeola, IgG, and IgM that were both negative.
They are among the bands. But what's interesting for those of us who remember when we saw that, their IgG index is astronomical. Sometimes their IgG makes up 50% of their total protein in the old days,
wow.
in the adolescent and teenage boys.
And no periodic progressive complexes on EEG.
Which would be a little against it as well, yeah. So, but worth thinking about, you never know.
Yeah, yes. No, for sure. All right, so we had several other imaging studies done over her hospitalization, and I apologize for kind of the order. I was just trying to, get everything in somewhat of a succinct way. So her CT angio of her head was normal without any evidence for kind of a vasculitic or vasculopathy process. As I mentioned before, her CNT MRI, spine MRI was normal. We checked her CT chest, abdomen, and pelvis, which did not show any evidence of malignancy. Her whole body PET showed kind of a non-specific brain uptake pattern, but no evidence of malignancy. We did a transvaginal ultrasound due to concern for NMDA. There's no evidence of adnexal masses. Her transthoracic echocardiogram was unremarkable, and her chest X-ray was clear on admission. Other studies, we did an EMG nerve conduction. She did have these abnormal movements on exam. We wanted to see, is she having, are there any evidence of fasciculations, positive sharp waves, and she did have fibrillations and positive sharp waves in her left bicep. That was thought to be consistent with more of an irritable myopathy, but nothing, kind of smoking gun etiology that was evident on the EMG. We then proceeded with muscle biopsy given these abnormal EEG results. And again, there was no evidence of inflammation, vasculitis, or regenerating or generating fibers. And a mitochondrial panel was also sent on this that was negative.
But she also had the elevated CK and aldolase. But if she's constantly contracting her muscles, that is more likely the etiology, and maybe just finally enough damage just from having your muscles contracting all the time. That's what it sounds like.
Exactly. Yeah. And this was, I think, if I remember correctly, this was a few, a couple weeks into her hospitalization. Right. So that could definitely be the case for sure.
There was no evidence of focal dystonia or axial muscle stiffness or any kind of posturing along with this myoclonus. There was no like opistotonic posturing, nothing like that.
She did actually, she had almost like kind of like a torticollis. She did have kind of cervical dystonia, and we actually had our movement disorders team come and Botox her because she was having specifically the most severe, I think, was the cervical, but otherwise she did have some kind of tonic posturing of her arms and legs. She was kind of flexed in the uppers and extended in the lowers on admission, and that kind of
glucose, peripheral glucose, and her hemoglobin A1C. No evidence of emerging diabetes.
No, her peripheral glucose was normal from what I remember.
Okay.
Yep. All right. So where we are right now in terms of her care after all of the evaluations, due to her lack of improvement, we and kind of rule out an infection at that point. The original plan was for her to undergo plasma exchange, but she actually developed DIC that was from Candida albicans fungemia of an unclear source. And in the course of her DIC, she became acutely anemic, coagulopathic, and thrombocytopenic, and she was transferred to the ICU. She was found to have a large rectus hematoma, duodenal oozing, and gastritis that were also thought to contribute to her hemoglobin drop. So she was treated appropriately for her fungemia.
Funny looking red cells to go with the rest of the TTP picture.
What's it? Oh no, it was mainly more DIC. Yeah.
Okay.
Mm-hmm. So because of all this happening, we didn't think Plex was appropriate. So she received a 5-day course of IVIG. And after that, she did have some improvement in her mental status. She was oriented to self, which was an improvement over her being nonverbal. So at this point, we kind of reevaluated again, and she was very minimally improving on standard immunomodulatory therapy. We thought more about kind of rapidly progressive dementia as kind of alternative causes for her. So we looked at subsequent MRIs, and I'll show you on the next slide here. Again, we were trying very hard to figure out what was going on with her. You can see on the DWI potentially some areas of cortical ribboning, especially where I'm pointing here. So that was concerning to us. And we actually repeated the LP, and it was positive for 1433 with an extremely elevated tau of over 2,000. But the RT Quick study was negative, the confirmatory testing.
My 1433 is always high when I eat pizza, so I don't know what that means.
Yes, no, definitely. We definitely learned this as a cautionary tale. Yeah.
A specificity issue there, but okay.
No, of course. And I think we were kind of reassured by the quick. I'm sorry?
So Dr. Froman, 1433 is just a marker of neuronal damage, just like tau?
Yep. Thank you.
I mean, and Laura has, and her references, some reviews. You should see it elevated in CJD, but it's not the only thing you see it elevated.
Sure, sure. Yeah, spongiform changes, neuronal dropout, just as Ram says. That's right. And as Laura says, but you know, you got the quick negative. Yeah, so.
Exactly. So at this point, we also looked more at kind of specialized antibody testing. So I mentioned before about the MA1, MA2, but we did send anti-GABA receptor antibodies, which were negative, as were AMPA and glycine antibodies were negative. At that time, Oxford was the only team that was doing them that we knew of, so we actually sent them to Oxford and they were negative. Her serum GAD65 was 2 with a reference range, as you can see, of less than 0.02. And I say this with the caveat that her testing was sent after the courses of IV Solu-Medrol and IVIG, as well as this, critical illness, hospitalization, and DIC and everything. So we were, our interest was piqued in this because it was kind of the first thing to come back abnormal with her, but we kind of took it with a grain of salt, especially in the setting of her CSF GAD65, which was also sent after the immunosuppression, which was negative.
But she's not diabetic, so that's important to know.
I had already asked that, yeah.
Right, exactly.
So 2 weeks after her receiving IVIG, she did end up undergoing plasma exchange for 5 cycles due to our, strong suspicion of an autoimmune etiology at that point. Especially when the RT-QuIC came back negative on her CSF. And during her course of plasma exchange, her mental status actually improved significantly. She was holding appropriate conversations, was fully oriented at times. So we were, of course, very encouraged by this and wanted to kind of more longer term treatment. So she had an initial dose of rituximab following the course of plasma exchange. And she had a repeat lumbar puncture that was definitely different than what she had at admission. Her protein was elevated at 95. Glucose was still normal. She had a few nucleated cells and only 3 oligoclonal bands. And again, we sent a sample to the National Prion Center, and her 1433 actually and tau actually went down, which is an improvement compared to her pre-plasma exchange CSF. And I made a table here of her lumbar puncture results so you can see kind of how things change over time for her. So her first LP, which was prior to her Solu-Medrol, as I mentioned, she had those 10 oligoclonal bands on admission with a mildly elevated IgG index. Her second LP after the steroids, her protein had started to go up at that point, but her bands were actually 0. She got IVIG, plasma exchange, and then rituximab. As you can see, her protein goes up, and then her IgG index and synthesis rate go up as well. So I'm not 100% sure what to make of the synthesis rate kind of going up, but we were, of course, very encouraged by her clinical improvement at the time.
The CSF using the synthesis rate, if you notice the various McDonald criteria, ignore that completely, because if you can ever figure out what the formula that Wally put together means, it's got so many multiples of so much that anything that slightly changes has
right, and especially with her protein going up, I think that the
IgG index, you got to worry about that too, and worry about whether her serum albumin went down because malnourished. So that the bands are not influenced as much. The others are, by definition, are mathematical formulas, so everything goes into it.
So here's my question about this: is I can't figure out a biological process. Sorry, Josh Katz from Boston, where you have 10 oligoclonal bands and basically 13 days later, 0. I don't know how that could happen under any circumstance.
Yes,
no, definitely.
Well, I would ask whether the same technique was used.
She was in the same hospital, so presumably they would have used the same lab technique. So.
Yeah, because if you follow in the old days, mumps meningitis, which would go away on its own, or treated crypto or TB, you're right, they don't go away in a week.
Right. No, definitely.
It makes me wonder if that's the one outlier that may be an incorrect value. And actually, a lot of this case hinges on, if it weren't for an inflammatory CSF, this is a sort of a toxic metabolic encephalopathy.
or until you had the negative prion Creutzfeldt-Jakob.
Right.
This is Doris. There's a question in the chat from Carla Francisco who wants to know if the LGI1/Casper2 was sent.
Oh, so so the voltage gated potassium channel kind of umbrella test was sent to Mayo, but they didn't have individual LGI1 Casper2 testing at the time.
I think they do that as a reflex. They do that as a reflex, so I think they screen with the potassium complex.
Right.
And for the rookies on the line, let's remember we have the paraneoplastic workups, but then we have the non-onconeogenic cell surface antigen antibodies. So GLY, AMPER, NMDA, Casper, L1, all of these have become very, very important, and they have some prognostic issues in terms of response to immunotherapy.
And they do have this other panel, which admittedly overlaps.
Yeah.
Elliot, this is Andrew Goodman in Rochester. I just want to make a follow-up comment to what you just mentioned. I think very commonly it happens in our hospital with inpatients. CSF will be sent for a paraneoplastic panel, but not for autoimmune.
Right.
And so all the antibodies that you mentioned will not necessarily be tested unless, as Bob mentioned previously, a sharp person in the Mayo lab picks up on something or reflexes to additional antibodies based on the story.
So they have the two panels now, Andy, and they do obviously overlap because some of them are both autoimmune encephalitis and paraneoplastic, and some of them are so rarely paraneoplastic they are not in the paraneoplastic. Some of the GABA, for instance, receptors are not part of the standard paraneoplastic, but they're in the autoimmune.
Yeah. So for that,
that's
on the line, that's Andy Goodman from Rochester, and Andy, that's a really, really important point because a lot of times people check the Athena, the paraneoplastic, they think they're getting all that, they're not. So it's very important to point that out. Great point.
And at Mayo, I believe the panels that they do that are the most comprehensive are the autoimmune encephalopathy panel compared to the paraneoplastic. That will include all of those.
That's correct. That's my point. And often it gets ordered incorrectly, particularly in the electronic, digital system.
Well, I still handwrite my orders.
Laura, is that your last slide?
Nope, I have a couple of next things. So kind of outcome of the patient. So after getting rituximab, she was discharged to inpatient rehab and then returned to the hospital 2 weeks later for her second dose. And at that time, she was speaking appropriately, walking with a walker. She was standing unassisted and was ready for G-tube removal. So I think that, is definitely a positive outcome for her. Which we're very happy about. And our working diagnosis for her was PERM, progressive encephalomyelitis with rigidity and myoclonus. And as I mentioned, the GAD65 antibodies are a little of questionable significance given the fact that they were tested after the immunosuppressive therapy. But this entity is associated with GAD65, so we were kind of putting them together there. So just a brief discussion about PERM. It's extremely rare. The clinical presentation is generally that of CNS hyperexcitability. Patients have hyperpexia, tremor, myoclonus, hyperreflexia. They also have rigidity, encephalomyelitis. They can often have brainstem involvement with oculomotor and bulbar dysfunction, as well as autonomic involvement. In terms of diagnostics that we see with PERM, so MRI can be normal and can also have some white matter lesions and atrophy. You can also see temporal lobe inflammation, similar to kind of limbic encephalitis, or like a pattern more consistent with small vessel disease. EMG can also be kind of a spectrum of findings. There can be continuous motor unit activity. There can be spontaneous or stimulus-induced activity. There can be sensory neuropathy, neuromyotonia, or it can be normal. Similarly, EEG can have quite the spectrum. It can be normal. There can be epileptiform activity, or there can be slow activity. In CSF, there can be pleocytosis, elevated protein. There can be algoclonal bands, or again, this can be normal. And these diagnostic findings were based on a series of glycine receptor positive patients that were reported in 2014. Other antibodies that are associated with PERM, as I mentioned, glycine, GAD65, DPPX, which is a component of voltage neuronal potassium channels, voltage-gated potassium channels as well, has been associated with anti-amphiphysin, which are generally paraneoplastic, and then anti-Re or Ana2. And from my reading, generally the treatment of PERM is immunomodulatory, kind of the standard combination of steroids, IVIG, steroids, plasma exchange, and there have been some case reports of other therapies discussed in the literature, but of course the degree of evidence is limited by the rarity of the disease. And I was also surprised to read about the outcomes of PERM. There are several case reports of PERM being fatal, and DIC apparently is not uncommon with this entity. Patients have also had respiratory failure due to the critical illness. And then the case series that I mentioned with glycine receptor antibodies, 33 of whom had PERM, had most of them recovering to modified Rankin of 1 to 2 after immunomodulatory therapy. So those are my references if anybody wants to read anything. So.
Okay, let me just, I'm going to take Chair's prerogative and just say, you rock. You're fabulous. You rock. That's all I'm going to say. In fact, now that I've heard your presentation, I don't know what's wrong with me, but I'm coming to Cleveland Clinic to see you.
Oh, thank you. I appreciate that.
The glycine is kind of interesting because many years ago, and I don't know if this family was ever written up, William Bank, who was a neuromuscular guy at Penn, had a family, and I think they were Middle Eastern origin, but I can't remember the details, a whole series of brothers who had a lot of these, not the encephalopathic, but a lot of this almost stiff type and all these other type movements and posturing. And they had increased glycine in their, I believe, their plasma and also the urine. And I don't know if Bill ever wrote them up, but it's kind of interesting. If you assume that the antibodies block glycine, you would get extra glycine. I wonder if anybody's looked at that in the antibody patients, because in this family, it probably was, and it was pretty definitely genetic. It looked like it was, I can't remember if it was X-linked or dominant because they had mainly sons. But so it's kind of interesting with the glycine antibodies in that family of Bill's. One of these days, try to find and see if you ever reported.
No, for sure. Yeah, the information kind of coming out about anti-glycine antibodies, I think Mayo's planning on having a commercial test available for it relatively soon, and they just published kind of their experience with it so far because they have been doing it on a research basis. It's been very interesting to see what they found the GAD65 negative stiff person syndrome patients, as well as several other kind of phenotypes with like vision loss and things like that. So it's been very.
One of the other problems with the GAD is that, as far as I know, the Mayo and any place else that's doing it only do the 65, which is shared by CNS and pancreas. I think Marinas Dalakis reported some cases many years ago, which were somewhat atypical, and they had the GAD67, which is only CNS, but that's not commercially available at the Mayo or any place else that I know of. I don't know if anybody does it as a research test. I don't think Marinas does anymore, but he reported some that had 67 but not 65, and it was useful if the person also had insulin-dependent diabetes, because that would be 65. Their titers are usually lower with diabetes, by the way.
Right, exactly.
Well, I think I'm going to take prerogative and bring this amazing, very dynamic, both of you, just spectacular, bring this to a conclusion. I look forward to getting the transcripts from Doris, and we'll be sharing them with you. But I have a strong suspicion I'll be speaking to my co-editor, Scott Zamville, and my other colleagues, but I think these are two that are fabulous and highly deserving of strong consideration for publication, God willing, in the new section in N2. So really fabulous work by both you guys. Any last comment, Uncle Bob?
No, these guys are great. If I was still a chair, I'd try to recruit them.
Yeah. So I did hear from Lakshman, so we know what he's doing. Laura, what are you doing at the end of the fellowship?
Oh, sure. So I'm in my first year of 2 here. So I'm actually just starting the job search kind of this semester. So I'm working on it. We'll see.
Well, we got a new chair coming. I'll give them your name.
Okay. Thank you. Thank you.
It was great. Both cases and both presentations and illustrations was terrific.
Okay.
Really terrific.
Fabulous.
Have a good night, everybody.
Thanks so much.
Thank you.
Doris, thanks for
Thanks,
organizing.
everyone.
Thank you, Doris. We can do it. Thank you.
Bye.
Great, Laura. You rock.
Bye.
Bye.
That was